So our topic for today on Tuesday the 31st of October is trauma-informed care. Let's do some introductions. So I'm Maggie Rosario. I am the chair of the Psychological Professions Network in the East of England. And Lara, would you like to introduce yourself?
Hi everyone, I'm Lara, Senior Assistant Psychologist working for the PPN East of England, and I'm also a psychological wellbeing practitioner working for our Talking Therapies digital team.
Thank you, Lara. And Emily, why don't you introduce yourself?
Yeah. Hi everyone, I'm Emily. I'm also one of the Senior Assistant Psychologists working in the PPN and the Talking Therapies digital team.
Thanks, Emily. And Fumi.
Hi everyone, I'm Fumi and I'm also one of the Senior Assistant Psychologists working in the East of England PPN and the Talking Therapies digital team. It's nice to be with you all today.
Fantastic, excellent. Let's see the next slide. Okay, and we are joined today by our fantastic PPN Lived Experience ambassadors. Melanie, are you here?
I am indeed. Hi, I'm Melanie Goodwin, and I am an expert by experience with a special interest in dissociative identity disorder, as I live with that particular condition. But I come with a much wider remit, and it's such a privilege to be part of this opportunity to share with you. Thank you.
Thank you, Melanie, and we're delighted to have you today. And Kayla, please introduce yourself.
Hello everybody, I'm Kayla Grist. I'm a Lived Experience ambassador. I'm also a volunteer for Essex Partnership University Trust. I'm a member of the PPN Workforce Council. I'm a member of the Service Development Collaborative and also the Service User Network. It's very nice to be here with you.
Thank you, Kayla. Thank you for making time for us amongst all of the other things that you do. And now to introduce everybody to the last member of our PPN team, Hina, would you like to introduce yourself?
Of course. Hello, my name's Hina. I'm a trainee clinical psychologist at Hearts in my third year, and I'm really happy to say I'm part of the PPN for the next few months. So I'll be happily joining a lot of these meetings. I'm looking forward to spending some time with you all this evening.
Thanks, Hina. That's a great introduction. Okay, and to the next slide. So we have a fabulous steering group that supports this community of practice. They give us their feedback, send us suggestions, and are generally involved, and we're really lucky to have them. I can see Kevin here today, but I'm not going to introduce the individual members of the steering group, but just to thank you and to let everybody know that we have a steering group also contributing to our work. If you'd like to join the steering group, please contact us at the PPN in the East of England. You'd be very welcome. And I'd like to invite everybody else to introduce themselves in the chat. Do put your name in so that we know who's here with us today. Shall we move on to the next slide? Emily, you're going to talk us through the ground rules, aren't you, for this meeting?
Yeah. So this meeting is being recorded. So as Maggie said, if you can all keep your cameras off and your microphones on mute, that would be really helpful. This is a safe and confidential space, and if you would like to ask a question or say something, can you please put it in the chat? We are asking that you use the chat rather than the raise hand function for this meeting. This session is slightly different to others that we've run, so Maggie will give some details on sharing information and discussion shortly. But we want this to be a respectful and non-judgmental environment, so we ask that you respect others' opinions and thoughts, even if they are different from your own, to make this as supportive of an environment as possible.
Emily, thank you. Shall we move on? Okay, that's great. I can see people introducing themselves in the chat. That's fantastic. So that's our agenda. We've done the welcome and introductions. Emily's done the ground rules for us, and now we're just looking at the meeting format. In a minute, I'm going to give a note about today's session. Then Kayla and Melanie primarily, and a little bit for me, we're going to be introducing you to trauma-informed care, and then there'll be a chance for you to ask some questions, and then we'll ask you to complete a feedback form for us. Then we'll be introducing the next meeting, and then we'll close. Please do give us your feedback. We really value it, and we really change what we do in accordance with that. So please do give us your feedback at the end. Shall we move on? So a note about today's session. Please do take care of yourself. Take a break from the meeting if you need it. Please be aware of other people. Think about others in the room and what their needs may be and what might cause them distress. That also includes thinking about our guest speakers and being respectful to them as well. I don't doubt that you will be, but just to put it out there. This isn't a good space for sharing trauma generally or things that may have happened. This isn't a good space for that right now in this meeting. Please be mindful of what you do put in the chat, and please make use of the support if needed. So we're going to put some contacts for support in the chat. Do feel free to make use of them, and we'll repeat them again at the end. Thank you. If we could move on. Lovely. I really do want to make an acknowledgement. So some of the slides and content from today's session has been kindly provided by our colleague and friend, Dr. Nick Gray at Sussex Partnerships NHS Foundation Trust. Thank you to Nick. And again, just a note about feedback. Please give it to us at the end of the meeting and do put your questions in the chat, as Emily said. Fantastic. Could we have the next slide, please? Thank you. So trauma-informed care and introduction. So these are the key concepts that we're going to be considering this evening. We're going to be considering trauma and adverse childhood experiences, and then thinking together about how we deliver care. Next slide, please. Okay, so what is trauma? Trauma results from an event or series of events or a set of circumstances which is experienced by an individual as physically or emotionally harmful or life-threatening, with lasting adverse effect on a person's functioning and mental, physical, social, emotional or spiritual well-being. Next slide, please. So how common is trauma? At least 55% of people will experience at least one trauma in their lifetime. 1 in 3 Muslim students have experienced abuse whilst at university. 1 in 4 women will experience domestic abuse at some point in their lifetime. 4 in 10 transgender people have experienced hate crime in the past year. 3 in 10 women and 1 in 10 men in the US have experienced rape, physical violence, and or stalking by a partner. 1 in 5 children have experienced severe maltreatment. So really that's just to give you a sense of how common trauma is. If you think about at least 55% of people will experience at least one trauma in their lifetime. Okay, so we have the next slide. So what about the link between trauma and mental health problems? Most people in Western societies will experience a traumatic event in their lifetime. About 20% of people who experience a trauma go on to develop post-traumatic stress disorder. 90% of people using mental health services have experienced at least one trauma. And about 2/3 of people with complex emotional difficulties, so emotional unstable personality disorder, for example, have experienced childhood sexual abuse. And people diagnosed with schizophrenia are 3.6 times more likely to have been victimized in some way in childhood than people without the diagnosis. What about adverse childhood experiences, or ACEs? So these are highly stressful and potentially traumatic events or situations that happen during childhood and or adolescence. They might be single events or prolonged threats to and breaches of a young person's safety, security, trust, or bodily integrity. Adverse childhood experiences directly affect the young person or their environment. Adverse childhood experiences affect the way that young people feel, behave, and view the outside world. So what kind of experiences are adverse? You can see maltreatment, violence and coercion, being forced to adjust to complicated life circumstances, prejudice, household or family adversity while you're growing up, inhuman treatment, having adult responsibilities when you're still a young person, suffering from bereavement or surviving illness or accidents. And how common are adverse childhood experiences? So 52% of the population of young people don't experience any ACEs, but the other 48% of those 23% have experienced one adverse childhood experience. 16% have experienced 2 to 3 adverse childhood experiences, and 9% have experienced 4 or more adverse childhood experiences. Shall we move on? So what is trauma-informed care? Trauma-informed care is an approach to delivering care which recognises the impact of trauma and adverse life experiences on people and groups and communities, and the barriers that are created by trauma and adverse life experiences. Trauma-informed care recognises the effect of trauma on neurological, biological, psychological and social development. It resists re-traumatizing individuals, so reactivating the thoughts and the feelings and sensations that were there at the time of the trauma. Trauma-informed care recognises the value of relationships and individual strengths. It realises that previous trauma and adverse childhood experiences impact on relationships and the ability to seek or benefit from help from others. It's also increasingly recognised that staff may also have experienced trauma and adverse childhood experiences. Could we have the next slide? Lovely. So now I'm going to hand over to Kayla and Melanie for the next section. Kayla, you're first.
So these are the 6 principles of trauma-informed care, as shown on the government website. First principle is safety. The physical, psychological and emotional safety of clients and staff is prioritised by people knowing they are safe or asking what they need to feel safe, there being responsible freedom from threat or harm, attempting to prevent re-traumatisation, and putting policies, practices and safeguarding arrangements in place. And I should have said before I started that I'm doing the 6 principles of trauma-informed care from my own personal experiences. So with regard to safety, having lived through several traumatic experiences, including domestic violence, physical, emotional and sexual abuse, my entire life, finding places that I feel safe is very important and also very difficult. Many individuals that have trauma background need somewhere to feel safe before they can try to be open about what has happened to them. Trustworthiness. Transparency exists in an organisation's policies and procedures with the objective of building trust among staff, service users and the wider community by the organisation and staff explaining what they are doing and why, the organisation and staff doing what they say they will, expectations being made clear and the organisation and staff not over-promising. Growing up in an abusive and neglectful home environment where those in caregiver roles were responsible for the trauma. Forming trusting relationships is exceptionally difficult for me. I crave honesty and transparency from people, as this and so much more was missing from my childhood and onwards into adulthood. Can I have the next slide, please? Choice. Service users are supported in shared decision making, choice and goal setting to determine the plan of action they need to heal and move forward by ensuring service users and staff have a voice in the decision-making process of the organisation and its services, listening to the needs and wishes of service users and staff, explaining choices clearly and transparently, and acknowledging that people who have experienced or are experiencing trauma may feel a lack of safety or control over the course of their life, which can cause difficulties in developing trusting relationships. My recovery journey has been quite short in comparison to others. I've been exceptionally lucky to be able to stay in the community, allowing me to raise my 3 children. Choice has been such a small part of my journey so far. However, the further I go, the more chances I get to make supported, healthy choices that aid my recovery. One of these choices was to get my ADHD assessment through Psychiatry UK, instead of waiting possibly years for my GP to actually take notice and refer me for assessment. Can I have the next slide, please? Collaboration. The value of staff and service user experience is recognised in overcoming challenges and improving the system as a whole by using formal and informal peer support and mutual self-help, the organisation asking service users and staff what they need and collaboratively considering how these needs can be met, and focusing on working alongside and actively involving service users in the delivery of services. The idea of collaboration regarding my own healthcare still befuddles me. I'm able to collaborate with others in my volunteering roles, but not within my healthcare perspective. It still eludes me, probably due to not having a current care plan in action. I was 47 years old before I ever heard of peer support, and I can only imagine how different my life would have been if I was able to have access to this type of service. To be able to connect with another living soul who can relate to just how difficult the fundamentals of life are for me and people like me. Even now that I've been learning to try to rewire my brain, being able to converse with like-minded people means so much. This is why I worked so hard on becoming a peer support worker. Empowerment. Efforts are made to share power and give service users and staff a strong voice in decision making at both individual and organisational levels by validating feelings and concerns of staff and service users, listening to what a person wants and needs, supporting people to make decisions and take action, and acknowledging that people who have experienced or are experiencing trauma may feel powerless to control what happens to them, isolated by their experiences and having feelings of low self-worth. Throughout my time as a service user, being a member of a personality disorder and complex needs support and awareness group, I've always felt empowered. It's given me hope of a better reality than the one I had looming before me. It's given me the ability to realise and accept my self-worth and the inclination to educate myself on mental health. I only feel strong enough to volunteer and become a peer support worker because of the empowerment I feel from the Service User Network. Can I have the next slide, please? And the last principle is cultural considerations. Move past cultural stereotypes and biases based on, for example, gender, sexual orientation, age, religion, disability, geography, race, or ethnicity by offering access to gender responsive services, leveraging the healing value of traditional cultural connections, and incorporating policies, protocols, and processes that are responsive to the needs of the individuals served. Unfortunately, this is a principle where some current care providers seem to fall short. Even in this day and age, people are still treated differently because of bias or the stereotypical, we are our diagnosis and not we are all human. Stereotypes and stigma still have a hold over some care providers. I've been stigmatised for being a teenage mother, a sufferer of emotionally unstable personality disorder, a government benefits claimant. I've been stigmatised on my educational level and my sexual orientation. And through all these instances, it cements the feelings of isolation, abandonment, and the feeling that I will never be good enough to contribute in any way that matters, or even just be worth listening to. And even though I'm an older, white, cis female, I still encounter these biases. I can only imagine how difficult these things are for those from more diverse backgrounds. These challenges can happen to any one of us. But why should they? Is it fair? Does it make people feel safe, trusting, included, equal, empowered, or even human? Can I have the next slide, please? So these are the trauma-informed care principles from the Mind website. Some mental health services are starting to follow an approach called trauma-informed care. If a service claims to be trauma-informed, it means that all staff should follow principles such as understanding how trauma can affect people, including how mental health difficulties can be reactions to trauma. Asking sensitively about past trauma and offering appropriate support if the service user discloses it. Being aware of the potential for mental health services to cause harm if delivered without trauma awareness. Understanding the service user's strengths and recognising what has helped them survive and cope. And being trustworthy and transparent and involving the service user in their care. Can I have the next slide, please? So why is trauma-informed care so important? Trauma-informed care shifts the focus from what is wrong with you, i.e. your symptoms or your diagnosis, to what happened to you, which would be the trauma and your personal experiences. The next slide, please. And now I'd like to hand over to Melanie.
Thank you very much. Okay, so I look at it as it's really important for me for people to understand the difference between the trauma-informed care and trauma therapy, because I think often when I'm listening, I get bogged down and realise that people are very muddled about where the lines stop. Trauma-informed care to me is something that every point of contact in any service we use should be absolutely embedded. What your whole learning is built on. But the trauma therapy is going to be done by therapists in a sort of safe setting with a very different focus to trauma-informed care. So everyone working in any caring profession should understand the trauma-informed care, and it should be the way they work in all situations, embedded as good practice. It allows the client to be heard, valued, and empowered. Helps the clinician to stay grounded, not to become defensive. Because I think often people who've, unprocessed trauma can make us all behave in a way that we perhaps outside our absolute control. And it can feel threatening, it can feel challenging, it can feel so many things. But if it's understood in the context that so many behaviours you will be witnessing within your professions will be based on past trauma, it gives you an understanding and a compassion towards what's actually is happening. It may enable the start of a mutual relationship built on trust, which Kaylee was so eloquently talking about just now, because the one thing that really goes, especially if we're talking about childhood abuse and adult abuse, but for many with childhood abuse, they won't have had a time before where they were getting good enough care. It would be their only experience of care. So trust is something that's everyone has to build up, but you have to earn our trust, and I have to earn your trust. It's a reciprocal thing. because I want you to trust me that I am able to manage myself at some levels and not undermine the ability to empower us. It enables the clinician to witness and reflect on possibly complex behaviours that may be responses to trauma-related triggers. And you possibly won't know what the triggers are, and maybe the person in front of you hasn't got a clue what the triggers are. You know, early on in our recovery program, we're totally unaware of triggers. We might be totally dissociated from the fact that, you know, our childhood situation. So we're a body of reactions, a habitual sort of response that can be really challenging, can be really annoying as well for both you and the person concerned. But with understanding through trauma focused therapy, you know, then the understanding comes, our triggers can be identified, and then, as Kaylee was talking about, the choice comes in, but choice in a slightly different way. The choice is about how I might want to respond to a situation, because before that I was a reaction to a situation with very, very little, if any, control over it. It prevents a controlling, punitive approach by the clinician, because I think if a clinician feels they're out of their depths and not coping, perhaps they're trying to control the situation, and it can be received, it's not meant punitively, because it can be received as a punitive approach to working with us, which again is repeating what we experience so much possibly throughout childhood and often as an adult. It allows for a genuine forum for working in partnership rather than the hierarchical situation that often arises in the consultation room. So often in so many, I mean, there's traumas that are accidents that happen, which are incredibly traumatizing, but we're talking perhaps much more about what people impose on people type traumas. And so we've been so disempowered, and so that genuine working in partnership to help us to re-establish or establish for the first time that we have a right to have feelings, we have a right to be there, we have a right. I always felt I didn't justify the space I actually took up in the universe. I really didn't think I'd earned that role, that position. Now I think, yeah, actually well, I have. But, you know, you can't overemphasize the impact of ongoing trauma can have on how we react to the world. Respectful and considered listening and responding allows the client to begin to do the same. You're very much a role model for us. So if you can stay grounded and compassionate and receptive and listening, then we can begin to think, oh, you really care. And that might be a way of us beginning to think how we might like to change our behaviour. But also, I think I can't overstress having the very first point of contact, whether it's through a receptionist, and the difference of a receptionist who is trauma informed or just treats us with courtesy and respect. You know, they might have to ring up to say they've postponed an appointment, which for somebody who's hanging on in there by the tips of their fingernails, it can be absolutely devastating, but delivered in a certain way, which can be, okay, this is really bad and I realise it's going to have a big impact on you. I'm really sorry, but we're having to reschedule. We have got another date. It's way outside that anything we can do about, but we really appreciate how this might be affecting you. I can go away, I might be cross about it, but at the same time I thought, yes, I've been treated like a human being, treated with respect and compassion, and I find a way of managing it rather than going away and perhaps not managing it. Next slide, please. I've got two slides about the window of tolerance. I love this because I was very, very hard on myself about how I was behaving and why I couldn't just change it all and why I didn't grow up, etc., etc. And by learning about what is the normal window of tolerance and then how badly it's impacted on trauma in childhood, it gave me permission to not go on repeating my behaviours that I didn't like, but it gave me permission to actually stop and look at them and confront them and challenge them and think about what I wanted to do. And it let me off slightly that actually this is outside just total micromanaging myself. It's much bigger than that. You know, my brain was wired in such a way. It took a long time for things to change. So I just want to share these, excuse me, two slides with you very briefly. You know, most of us hopefully work within a wide window of tolerance. where we sit most of the day and we're able to get on with our work. We will fluctuate, we'll go up and down during the day, whether tired, hunger, a situation arises which triggers us up there, or it makes us shut down a bit. But most of the day we're being that ordinary, I like to call it boringly grey area, getting on with everyday living. Your brain is functioning pretty well, you're pretty much in control, but in a nice way, from a deep way of being controlled. And then if we get distressed, we can recover very quickly from the intense emotions, and we're able to act but not overreact. And if you think about somebody who's had a lot of trauma, and that's a very narrow window, we so often overreact. And I'm sure you can all think of somebody you've been with, whether it's a friend, a client, whatever, who you thought, God, that seems a bit of an overreaction to the situation. But just bearing in mind that, you know, a lot of our behaviours are based on past traumas or just past experiences, it can lead to that. And then if our states of low activation are short-lived rather than feeling unbearable, and can be used for replenishment. So it's a way of recharging our batteries, whereas somebody who goes down into that level will often go into complete depression, unable to get out of bed. You know, it's the extremes. So we're either perfectly all right or we're in the pits, whereas most of our life we hope to lead in the middle of that way of being. Next slide, please. And then if you look at these trauma-based early attachments can lead to affect intolerance. So as you can see, there's a very narrow window of tolerance, where even a little emotion is hard to tolerate, partly because we've never had that perhaps been in the family environment where we've been metaphorically held, well, literally and then metaphorically held, and able to experiment with our emotions without being criticised or punished. So that is, it's really hard to tolerate. So we tend to fly up into the what we call sort of more of a manic type of situation. So it's an inability to tolerate immense emotion, leading to acting out. And I don't like the word acting out, but it's the word that's used here. But it can lead us to being how we really would rather not be. Addictive behaviour, self-harm or violence in an attempt to discharge excessive arousals and regain some equilibrium. And this is a place where people perhaps, you know, self-harm and things a lot, and you know, people can be very critical of that sort of behaviour, but actually with looking at it within this window, looking at it within trauma-informed care, it's understandable. It's hard, it's tough for both you, the person witnessing it, and us experiencing it, but there is a level of understanding. And then dipping down, so you have prolonged states of low activation, may become a way of life with hours or days spent numb and inert, disengaged or engaged without emotional connection, intense isolation. And I spent a lot of my life either absolutely, if I could get on, I got on, and I knew I'd only have so long being able to function, and I would cram as much into it as I could, because I knew shortly I would become immobilized. I felt very, very little time in that window of tolerance. And as I was a mum of 4 and worked and a very busy life, it was a real challenge. And I've had to learn that actually I can have a lot of the day now at a steady pace, getting on, where my brain engages and I have an ability to process and move on and do. I don't have to fit everything into a very short period of time before I perhaps dip right down and I'm immobilized. Next slide, please. Right, Kayla, thank you very much.
So a trauma-informed approach seeks to realise the widespread impacts of trauma and understand paths for recovery. Recognise the signs and symptoms of trauma in patients, families, carers and staff. Integrate knowledge about trauma into policies, procedures and practices. And I'd also like to see it integrated into education as well. And actively avoid re-traumatization. Next slide, please. Why is trauma-informed care so important? The photos that you'll see on this slide are of a community mental health waiting area. And as part of Essex Partnership University Trust's Hardworking Service Development Collaborative, of which I am a member, we were funded some money and we were able to update some waiting areas and make them a little bit more trauma informed, a little bit more comfy, cozy, safe feeling. So yeah, we added some mirrored tiles on the walls to bring in some more natural light because it was a little bit dark and dingy. We added some more plants. We added a box of fidget toys for people to use and take home, because that can sometimes help when you're feeling very nervous and you need something to do with your hands. We cleared all the walls looked very busy with posters and flyers and things. So we cleaned all that up and put in some nice lockable cupboards. And I made some lovely cushions with bees on because we thought that that would be a really good idea, not just for the waiting room, but for the staff as well. And the staff absolutely loved them. And it just brought instant smiles to their faces. So I feel quite happy that they went home smiling. But yeah, this is what Melanie was saying about trauma-informed care should start from the very first instance. So if you walk into a room and you have that feeling of safety and that feeling of it's not that bad, and you've got things around you that can keep your mind active, it's just a whole different ball game to walking in a bare room. No music, nothing to read, nothing to do, nothing to keep you occupied, nothing to hide behind. It just makes all the difference. So yeah, I just wanted to share, you know, some of the changes that have already started to be put into place for the trauma-informed care. Next slide. And back to Melanie.
Thank you. I nod off. No, I'm not nodding off. I'm not. That's the wrong expression. What I don't do is recognise when my own slides come up. Thank you, Kayla. I think they look vaguely familiar, and then I think, oh yeah. So the client and or clinician may become angry or passive. Neither of these situations are conducive to positive outcomes. And you know, if there's that unawareness of the person, these are very much trauma responses, they can feel very challenging, and there's this sort of attunement or lack of attunement in the room can be really negative for both the clinician and the receiver of that sort of attitude. Often the client's reality may be belittled or skirted over rather than validated. I think people are so concerned because they can't make us better, they can't cure us, they can't rescue us, that they tend to make it smaller than it really is. And in my personal experience and having talked to people over many years, is that the validation of, gosh, that sounds like a really hard situation, that must have been really tough for you. You go, wow, yeah, actually it was, and it helps me to feel less, so I've got to defend my own corner. So it, you know, we aren't expecting you to offer us the world in one appointment, but you can actually validate our reality and what we're sharing with you, rather than, you know, recently I had to have a brain scan and it's fine, but I can't go into a tube. And this was in physical health, but being asked, you really can't, you sure you really can't, didn't help me a lot. And that has really stuck with me, how, you know, that could have been such a different experience with just a very slightly different attitude and listening to the reality. You can open up traumas from the past too quickly, and this is a bit of a, you know, we're saying to you, listen and validate our reality, but we're also asking you to help us not to unpick the traumas too quickly, because that can be very destabilizing and very it can be disastrous. So we're wanting you to help hold us. So and this will be especially important if the person you're with has been used to managing by a high level of dissociation, and it's been their way of coping. So taking their coping mechanisms away too quickly can really destabilize people and undermines, but it's getting that balance right. So again, in partnership, explaining why, you know, you're hearing what they're saying, but this isn't the right place to be unpicking the trauma as such, and explain why, and sort of it's this discussion around it rather than you doing to us yet again. The importance of having experienced practitioners assessing and screening. So many clues in both the client's body and their language will often be telling a much bigger story that is so often missed. And I think we know how hard services are pressed. Absolutely, it's devastating out there for you as clinicians working. But so often in my area, we have somebody with a form asking a series of questions. They have been trained to ask this form with very, very little, if any, mental health training. And people then get signposted on to their next place they're going to. And in my opinion, I think at that first point of contact of mental health, it should be perhaps the most experienced clinicians there, picking up what might really be happening for that person. So we're not then pushed off down the wrong pathway and have to go through all the hoops. I felt like I was performing rather than actually getting help I needed. And often the hoops I was expected to jump through did me more harm than good. So I think that I feel really passionately about this is one of the big things that could change, so that people might not get the longer term therapy they might need or whatever they need right away, but being going in the right direction can help that client, that patient client, to feel validated and heard. To add to the trauma that the client has already experienced in life, and this is the one thing, is please try to do no harm. That, you know, if we can achieve that, that would be an enormous step forward within mental health work at the moment and screening. And I just am amazed that people still get up and go to work within some of the settings within mental health at the moment, because you are so understaffed. So, you know, we are aware of this. We're human beings, and that we have a level of compassion, but we actually need help, and we need to get the right help at the right time. And if it can, the least it can do is do no more harm, then that can be as good as it is able to do at the moment. Next slide, please. I think this is Maggie. Yes, good.
It is. Thank you very much, Melanie and Kayla. Really, really helpful to hear your perspectives. Thank you so much. So how can I adopt a more trauma-informed approach? So this is for us all to think about. So psychological professionals can lead the way and have a role in generating change, working in collaboration with colleagues and those who use services, their families and carers. So you'll see in the chat that Kevin asked a question about the triangle of care, and that describes the relationship between clinicians, individual patients, service users, clients, and their families and carers working together. So just thinking about what's happening across our region in trauma-informed care. So our local trusts vary considerably along a continuum, really from very small pockets of trauma-informed practice to a much more comprehensive approach, where the organisation adopts a trauma-informed ethos throughout, not just in the way that it interacts with people who use services, but also in its interactions with staff. So that's based on an understanding that the way that staff are treated then influences how they go on to treat others in their care. So as you develop and move forward in your careers, think about what you can do to enable those who've experienced trauma and adverse childhood experiences to come into and make the most of services that are intended to support them. So what do we all need to do differently? It is all of our responsibilities. Could we have the next slide, please? So this is one of Nick's slides, just thinking about how we examine care through a trauma informed lens. So if you work in services currently, or you have an opportunity to use health services yourself, put yourself in the position of someone who's experienced trauma and take a few minutes to walk through the service in their shoes from the first contact, as Melanie said, to the very last contact. Consider the communications that you've received, the buildings that you visit, the people that you meet and the interactions that you have, the physical spaces that you might encounter, and the policies that you would be affected by. Could we have the next slide, please? So then think about what could be changed. What would you keep and what would you do more of? Where in your walkthrough are you offered a trauma-informed experience, where the impact of trauma is recognised and you're offered safety, choice, collaboration, empowerment, trust and cultural consideration? What things would you want to stop or change so that the impact of trauma is adequately recognised and responded to, and re-traumatisation is minimised? Where in your walkthrough might you experience a service or practice that doesn't fit with these principles? Are there any places where the impact of trauma isn't recognised or responded to? Are there any policies, procedures or interactions that may be disempowering, coercive or lacking in collaboration? Are there any places where you may feel unsafe or that your trust might be breached? What would you want to do differently? What would you want to add into your service or your practice so that the impact of trauma is adequately recognised and responded to and risk of re-traumatisation is minimised? Are opportunities for empowerment, choice and collaboration currently being missed? Are opportunities for supporting recovery from the impact of trauma currently being missed? Can we move on to the next slide? This is a table that you can use to capture that. Things that you want to do more of, things that you want to stop or reduce, things that need to change. What do you want to keep doing? And the next slide, please. These next slides just are briefly recapping on the points and the principles that Kayla already talked through. And I'm going to suggest that we pause the slides here and we come back to them shortly to finish, but that we have some questions at this point, I think. Would that be all right, Melanie and Kayla? Fantastic. Oh, Kevin's asked, can we do a straw poll? Who had trauma-informed care in their courses? I'm not sure. I suppose we could ask people, put it in the chat if you had trauma-informed care as part of your course at any point. It would be really interesting to hear who did. Let's ask Emily, Fumi and Laura. Did it come up for you at all in your courses?
For me, it only came up briefly in my last year in a module when I was specialising in like clinical applications of psychology. But I think it isn't something that is often talked about to the extent that I think would have been really helpful. So I'm really appreciative that we get to talk about it now.
Thanks, Fumi.
I don't think it did come up in my most recent course, which would be around 18 months ago. And the courses prior to that, I don't recall it being spoken about then. But as Fumi says, it's really good to have that opportunity to hear about it now, and especially from our experts by experience as well, to have them in this presentation, Kayla and Melanie. So thank you.
Yeah, I'd say my experience is the exact same as Fumi's. It only came up in a specific module very briefly. So I think that's why this space and getting to hear from everyone is so important.
Thanks very much. And if anybody else would like to put in the chat whether they had trauma-informed care covered in their courses, that would be great to know about. Really interesting. One of the things I did wonder is just thinking about your experiences, Kayla and Melanie, out of safety, choice, collaboration, trust, empowerment and cultural considerations, are there any that particularly jump out for you as being really important?
I think it's a really good question, but you know, each of those is equally as important for somebody who came with, I mean, perhaps, yeah, because if you don't have the feeling that you're working with somebody and you're there to be done to, then the collaboration needs to start right from the start. Safety has to be paramount, because you're not much good if it's not a safe feeling of a safe setting. Choice, all these, one is so intertwined with all the rest. Choice leads to empowerment, leads to collaboration, doesn't it? So it's very entwined with being respectful and curious and all those other things, isn't it, for me? So I couldn't prioritize. If I had to choose one, I really couldn't do it. They're so intertwined. And part of, if you're just with somebody and you're being courteous, they're all there, aren't they? You're just automatically covering all those aspects of being a person in many ways. I don't know. What about you, Caleb? What's your thoughts on that?
Yeah, I would agree that they are all just as important as each other. But specifically for me, it has to be the trust and safety. I struggle, like I said while I was going through my slides, I struggle with feeling safe around people. I struggle being able to maintain any type of healthy relationship, and it's all because of what happened to me when I was a child. So that sense, the only sense of safety that I get now, I turned 50 a couple of weeks ago, and the only sense of like proper safety that I have now is when I'm at home on my own. But that's not good for my mental health, because then I'm isolating myself. So yeah, I think safety's a big one, and that trustworthiness and transparency, I think. All the others came along so much later in my recovery journey. But those two were the ones that I was missing out from, you know, childhood. So it would be those. And can I just say that sometimes I tend to think of trauma-informed care. The term trauma-informed care gets thrown about so often, and it's like a buzzword, or it can be thrown around like a buzzword, which frustrates me, because I don't look at it as trauma-informed. It's compassion. It's that compassionate care. I honestly feel like anyone that goes into a caring profession should go into it because they care about people. If you don't care about people, how can you provide them with care? And that's always been a question for me, always. So yeah, I like to see it as compassionate care, which everybody is capable of. All humans are capable of compassionate care. So yeah, that's my personal view. Thank you.
Can I just add there, Kayla and everyone? I think because I've been incredibly fortunate to have had a lot of very, very good therapy, and I didn't feel safe in therapy for years, and I didn't trust for years, and that began to really become established by being in a safe setting, although I couldn't feel it for a long while. And it came from working with me collaboratively, allowing me choice where choices were allowed, and all those other things that Kayla spoke about so well. So with hindsight, the trust and safety grew because of the other ingredients. So I think everybody's differently. And also we're trying to put in words to a journey, aren't we, Kayla, that we're all experiencing differently, partly from what was perhaps most damaged when we were children, but also the experiences of how we're being helped, you know, whereas Kayla's done it through a lot of her work on her own, as I've picked up over the time I've known her, through peer support and that sort of thing, whereas I didn't have any peer support, but I did have good therapy. So I think, you know, we all come to it in our own ways, and we're trying to make sense of things that made no sense. And if somebody had said, did I trust and did I feel safe as an adult prior to my life imploding, I'd have said, well, of course I do. But actually, when it came into therapy, I hadn't got a clue what it meant. It had been a facade I'd built to convince everybody else I was all right. And once that was slightly dismantled, these issues came up. So I think it's really just so hard, but we all are out there trying to make some sense of our own selves, aren't we, to be able to move on. Thank you.
Melanie and Kayla, thank you so much for taking the time to share your experiences so openly with us. Thank you very much indeed. Unfortunately, we've come to the end of our time right now for this section. If we could just move on with the slides, Lara. Beyond these ones, thank you. That's it. Exactly. So just to tell you that you can see recordings of our previous meetings, and we will put up this recording on our website too, so you can revisit it. We'll also provide some resources on trauma-informed care for you within the next couple of weeks or so. You'll be able to see this recording, revisit it. If we could have the next slide, please. So if you could click on the link that we're going to put in the chat, please, and give us your feedback, which will be so valuable about the meeting today. It's not a long form and it shouldn't take you long to do. But we're just going to give you a few minutes to complete the form now, if you would, for us. And then when you've done the form, we'll come back to talk about the next meeting. Okay, excellent. Shall we come back to the slides? If you haven't finished off the form yet, if you could do it and submit it for us, that will be so helpful for us. Hina, did you just want to run us through the next meeting?
Yeah, I can do. Can you guys hear me okay?
Yes, perfectly.
Brilliant. So we've been thinking long and hard about what we might want to do as a topic next time, and we wanted to go through how we might be using our time between applying for the doctorate and between that time and the actual interview process. So we'll have that set up for the 28th of November, and we will have some thoughts about maybe how to go about setting this up, and hopefully you'll hear from us in between if we have any of these ideas and any extra things that we want to action prior to this.
Thanks, Hina. That's really great. And actually, the topic from that we're proposing for November came from the feedback form. So it's one of the things that was frequently talked about. How can I get onto the clinical doctorate? What can I do between now and my next application? So that's how we've used your feedback to think about actually what we're going to do next. So if you're not already a member of the PPN, please do join. If you tick the box that connects you with the East of England, that would be really brilliant. It's a really short form. It's very quick. Being a member is entirely free. and you get to hear everything about what's going on. And we also have Psychological Professions Week coming up on the 13th to the 17th of November. If you go to our website, you can sign up to the events, which are also entirely free across the week. I think that is everything for today. Thank you very much for joining us. You've been very welcome. Thank you very much to our fantastic presenters and also to our PPN team. Thank you very much indeed. We've just put the contacts in the chat if you do want to seek support. There's plenty of support out there. Thank you very much indeed. And we will see you in a month's time. Thank you, everybody. Yes, the speakers were fantastic, weren't they? Thank you.